So today we're going to discuss a different situation, one where things have already progressed quite far. A patient gets an X-ray, and the radiologist reports something like fracture, compression fracture of the vertebral body, or fracture of the vertebral arch or processes. Lately, I've been seeing a lot of these patients. In fact, cases like this show up almost every week. When someone comes to me with such a diagnosis, I ask, "What exactly happened? What were you doing when this occurred?" And very often the answer is, "Nothing. I woke up in the morning and couldn't get out of bed. Something just locked up. My back suddenly seized." Another person says, "I wasn't doing anything unusual either. I was walking up or down a staircase, holding onto the railing. And suddenly, something gave way. My back locked up, and that was it." Someone else picked up a bag from the floor. Another person was taking a suitcase down from the overhead compartment on a plane. Someone bent over to tie their shoes. In other words, nothing dramatic happened. There was no obvious injury, no major strain. These are usually careful, cautious people who suddenly find themselves in this situation. The most alarming part comes next. They get their imaging results, and they're told, "You have a fracture." Now let's talk about fractures. First of all, a true fracture should heal. Any bone fracture heals. At some point you can see the fracture, and later you can see that it has healed. Eventually, the fracture is no longer there. So, if 2 to 4 weeks have passed, the picture should have changed significantly. Of course, that's true for a typical traumatic fracture. When someone falls, gets injured, or experiences some kind of accident. But in these cases, 3 months go by, and I ask, "Has the fracture healed?" And they tell me, "No. We took another X-ray, but for some reason it isn't healing." That's when I start asking a different question. Maybe it isn't actually a fracture. Maybe the X-ray isn't showing us the whole picture. This reminds me of a patient I treated about 15 years ago. She had been in a serious car accident. Her vehicle rolled over several times. She was pulled from the wreckage and taken to the hospital. Imagine the situation. Severe trauma, pain, breathing difficulties, the whole picture. She arrives at the hospital and she's told that 5 or 6 vertebrae are fractured. She spends 3 or 4 months in treatment, but nothing improves. The pain remains. The X-rays look exactly the same as they did on the day she was admitted. Eventually, she came to see me. I asked her, "Galya, do you happen to have any spinal X-rays from before the accident?" She laughed and said, "Of course not. Why would I have X-rays from before the accident?" And that's the problem. Because what I eventually concluded was that she had pre-existing microdisplacements in the spine. Those microdisplacements were causing pain. What appeared to be fractures were actually long-standing degenerative changes in the vertebral bodies and arches. Those changes had been there before the accident. The accident simply became the event to which everything was attributed. There was a dramatic incident. There were symptoms. And naturally, everyone connected the two. After about 3 or 4 weeks of treatment, her condition improved significantly. We're still on good terms to this day, and she has had no major problems since. The point I'm trying to make is this. Every vertebral body, every disc, and every structure within the spine is a living organ system. Each one has its own blood supply, It has arteries that bring nutrients, microcirculation within the tissues, veins that carry blood away, a lymphatic system, nerves, afferent and efferent pathways, and much more. Each structure also has its own shape and internal architecture. In our AMF diagnostic approach, anatomical, morphological, and functional diagnostics, we evaluate every organ, every vertebra, and the body as a whole according to these three principles: anatomy, morphology, and function. We often describe this concept using what we call an AMF cube. Why a cube? Because a cube has 6 sides. The first side is form. The second is internal structure and morphology. The third is function, how that particular body segment performs its role. If it's an organ, how it functions as an organ. If it's a vertebra, how it functions as a vertebra. If it's a disc, what role that disc is supposed to play. The remaining sides involve blood supply and lymphatic circulation, nervous system control and innervation, and finally the amount of energy and biological resources available to that tissue. Today, when we look at a standard X-ray, we only see bones. If we use contrast imaging, we may be able to see some arteries. If we perform more advanced imaging studies, we can observe how the contrast medium moves through the vessels and where it eventually drains. But we can't realistically do that in a detailed, continuous way in living patients. We can study these processes in animal models. You can't simply place a person under an X-ray machine for several hours, inject contrast dye, and continuously watch every stage of circulation. That's not practical. However, as clinicians, we need to have a clear mental picture of what's happening inside. We also need to understand that different structures receive blood supply in different ways. Take the vertebral body, for example. It has arteries supplying it, veins draining it, and its own circulation network. A disc is different. It relies primarily on diffusion for nutrition. It receives nutrients indirectly from the adjacent vertebral bodies. Then there are ligaments. There is the anterior longitudinal ligament running along the front of the spine. There are ligaments inside the spinal canal. There are ligaments attached to the spinous and transverse processes. And then we have the deep muscles of the spine. Some connect neighboring vertebrae. Others span 1, 2, or 3 vertebral levels. These muscles act as powerful biological pumps. But you don't see them on an X-ray. An X-ray can reveal bony asymmetries. It can show whether structures have shifted forward, backward, to the right, or to the left. What it cannot show is how the muscles are functioning. And because we cannot directly see that on the image, we have to reconstruct that part of the picture mentally. As physicians, we need to look beyond the image itself and visualize the entire functional system. Only then can we truly understand what's happening. For example, the spine receives its blood supply through 4 major vascular regions, one associated with the pelvis and sacrum, one around the thoracolumbar junction, one within the thoracic spine, and one within the cervical region. Now think about what happens when the shape of the spine becomes distorted. If the spinal curves become abnormal, blood flow and tissue nutrition begin to change. And where do we most often see pathological fractures? Areas of bone softening, osteoporosis, osteosclerosis, and degenerative changes of the spine. Exactly in those vulnerable regions. The next question is whether we can connect these changes to a person's posture and movement patterns. How do they sit? How do they walk? What positions do they spend most of their time in? What asymmetries exist in their body? Once we start viewing the body as a complete picture, things become much clearer. When I'm teaching students or physicians, we can often predict future problem areas before symptoms even appear. By looking at someone's posture and biomechanics, we can say, this person is likely to develop problems here, and this person will probably develop issues there. We can identify zones of increased stress, elevated risk, and future vulnerability. The problem is that most patients don't come in at that stage. They usually arrive after the degenerative process has already been progressing for years. By then, their primary concern is simple. It hurts. Something happened. Pain appeared. And very often there was some kind of sound involved. A crack, a pop, a snap that frightened them. They think, I barely lifted anything. There wasn't much weight in that bag. Something cracked, something snapped, and suddenly I couldn't move. But when you investigate carefully, you often discover that the sound wasn't caused by a bone breaking. It wasn't the vertebra crumbling. Instead, because of the existing deformations and restrictions in the tissues, some adhesion may have released, a fibrous connection may have separated, or something may have shifted within those anatomical spaces. There was a sound. There was pain. But in reality, nothing catastrophic occurred. This is one reason why routine health screenings can be so valuable. When patients undergo annual checkups, we can compare their current images with previous studies. And often we can say, these radiological findings didn't appear yesterday. Look at your earlier scans. The same changes were already present. The difference is that at the time, they weren't producing symptoms. The patient felt fine. There were no complaints. Today, the most we may find is some swelling around the painful area, perhaps some local tissue reaction. But the real question isn't what happened. The real question is, what do we do next? That's what truly matters. Let me show you a typical example. Here we see a vertebra that appears compressed and flattened. Was there a traumatic injury? No. This wasn't necessarily caused by trauma. Over time, because of osteoporosis, osteosclerosis, abnormal loading patterns, excessive lordosis, kyphosis, or other biomechanical stresses, the vertebra gradually deformed. It slowly lost its structural integrity. Its internal architecture remodeled itself, and eventually it became what we now see on the image. The discs, the blue structures you see in the illustration, have also changed. Remember, discs depend on diffusion for nourishment. When hydration and nutrient supply decline, they lose height and become flattened as well. Naturally, the facet joints and other spinal articulations begin to change too. Now consider the ligaments. There is a major ligament running along the front of the spine. There are strong fibrous ligaments inside the spinal canal. Some areas become detached, other areas loosen. Everything gradually begins to shift. One structure changes, then another, then another. And eventually, all of these changes combine into what we recognize as a clinical condition. What fascinates me is how extensively all of this has been studied and documented. If you open a standard anatomy textbook, you'll find detailed illustrations of these systems. The information is there. Let me show you another example. Here you can see the venous system, illustrated in blue. If the artist had chosen red instead, we'd be looking at arteries. The arteries and veins run alongside each other, and nerves travel with them as well. At least this image gives us a glimpse of that complexity. All of these venous networks form interconnected plexuses. People often ask, why are veins emphasized so much in these illustrations? The answer is simple. Veins are easier to compress. Even a small deformation can affect venous flow because veins are soft and flexible. Another reason is that there are far more veins than arteries. In terms of both number and total cross-sectional area, veins exceed arteries several times over. That makes them easier to visualize and illustrate. An artery may enter a region through just a few major branches. The venous network, however, spreads throughout the entire area because its job is drainage. But we must remember, where there is outflow, there must also be inflow. If venous drainage is impaired, arterial inflow eventually suffers as well. And once both are affected, microcirculation deteriorates. That is why discussions about circulation often begin with venous outflow. It's a critical part of the process. Here is another illustration. You can see how these vascular pathways are organized. All of the major venous channels run inside the spinal canal. The vertebrae surround them, while nutrients reach the tissues through a combination of direct vascular penetration and diffusion, driven by pressure gradients and movement. When those pressure dynamics are lost, when deformation occurs, the quality of that diffuse nourishment declines as well. Take a look at this image. Who does it remind you of? What we're seeing here is a sacrum that has tipped backward and become more horizontal than it should be. Normally, the sacrum should be positioned at roughly a 30-degree angle relative to the vertical axis. You may remember that I've shown the office Emma figure before. If you haven't seen it, it's a popular illustration that demonstrates what years of sedentary office work can do to the human body. Office Emma has all the classic features: degenerative changes, a pronounced kyphotic posture, a forward head position, rounded shoulders, a protruding abdomen, and a body that has gradually adapted to a desk-bound lifestyle. In most depictions, she's shown as a woman in her late 30s or 40s. And when these postural changes become even more pronounced, we're looking at someone who has spent decades putting wear and tear on the body. Let me show you another image. Here you can see the intercostal muscles. These muscles suffer as well. Remember, the vertebrae connect to the ribs, and everything functions as a single mechanical system. There are also deep muscles running very close to the spine itself. The primary role of all these muscles is postural support. They were designed to keep us upright. After all, human beings were not designed for a sedentary existence. We're meant to walk. We're meant to run. We're meant to move. We aren't rodents sitting in one place all day nibbling seeds and nuts. Human beings are built for upright locomotion and regular physical activity. At the very least, we weren't designed to spend our lives attached to a chair and a computer. Now look at this image. You can see 4 major points where arterial blood enters the system. The venous network, on the other hand, fills the entire region because it is responsible for drainage. These red vessels represent arterial inflow. And this large vessel here is the aorta. This brings us to a very important point. The heart and the aorta form the body's main circulatory highway. And where is that highway located? Right next to the spine. The spine is one of the first structures to receive its share of the body's circulatory resources. The relationship between the aorta and the spinal column is remarkably intimate. The aorta is practically attached to the spine. Now imagine what happens when we begin twisting, bending, and deforming the spinal column. The aorta wasn't designed to accommodate severe distortions of posture. Picture the aorta running here, while the spine develops all sorts of abnormal curves and twists around it. The body eventually starts protesting. From there, it's not difficult to understand how these changes can contribute to vascular disease, atherosclerosis, circulatory disorders, cardiac rhythm disturbances, reduced blood supply to the heart, even heart attacks. And if we move higher up into the cervical region, we're talking about vessels supplying the brain. which means an increased risk of cerebrovascular problems as well. Now let's talk about treatment. So, we have vertebrae that have become compressed and deformed. The patient is experiencing pain. What are our options? Do we simply treat the symptoms? Do we reduce pain with medication? Do we decrease swelling through anti-inflammatory measures and dehydration therapy? Or do we move toward more radical surgical solutions? We ask the patient, "Are you planning to continue living the same way you've been living?" And often the answer is, "Yes, I have a sedentary lifestyle." At that point, modern medicine can offer several options. One possibility is vertebroplasty. In simple terms, bone cement is injected into the vertebra so it can no longer collapse further. Patients often ask, "Can you restore the vertebra to its original shape?" And the answer is usually, "Not really." At this point, the spine has already adapted to its current position. What we can do is stabilize it and prevent further collapse. Another option is surgical fixation. Metal hardware, screws, rhodeeds, and various support structures can be installed to stabilize the spine. And this is where the question of strategy arises. Do we inject cement? Do we implant hardware? Do we replace structures? Do we mechanically reinforce the damaged area? These are all valid medical approaches. But our main point today is this. These so-called vertebral fractures are usually not isolated events. They are not random accidents. They represent the final stage of a process that has been developing slowly over many years. The tissue gradually deteriorates. The architecture gradually weakens. The structure slowly breaks down. And eventually, we see the result on imaging. What treatment to choose, and whether treatment is necessary at all, is always an individual decision. Now let's consider a different scenario. Suppose a patient is willing to undergo surgery and accepts vertebral cement augmentation or spinal fixation. That's one path. But suppose another patient says, "I understand what's happening. This experience frightened me. I want to recover as fully as possible. I'm willing to change my lifestyle, my daily habits, whatever is necessary. I'm willing to dedicate 1, 2, or even 3 months to rehabilitation." That's a completely different situation. In that case, our strategy changes. For example, we might begin by adjusting the angle of the pelvis. Even a small correction in pelvic alignment can reduce excessive lumbar lordosis. As soon as that happens, mechanical stress on individual spinal segments decreases. The curves become less extreme. Instead of concentrating force on a few overloaded areas, the load becomes distributed across the entire spine. The next step is restoring circulation throughout the region. How do we do that? By reactivating the deep stabilizing muscles of the spine. Look again at the pelvis. In many people, the pelvic angle has become almost horizontal. If we gradually restore a more functional position, the entire spinal column above it begins to change. Excellent anatomy textbooks illustrate this beautifully. The principle is simple. When the pelvis changes position, the compensatory curves of the spine change as well. And once we improve the foundation, we can begin correcting the structures above it. Just like constructing a building. You don't start with the roof. You start from the ground up. The same principle applies here. This situation can be changed. After alignment begins improving, we focus on the muscles. These muscles act as pumping and drainage mechanisms. They maintain circulation. They maintain tone. They keep tissues alive. Our task is to restore balance between the right and left sides, between the front and the back of the body. In our approach, we always pay special attention to the weaker side, not the stronger side, the weak side, because the weak side often isn't functioning properly at all. Once that balance begins to return, we move into the next phase. We work progressively through the higher spinal regions. If we have a month, we work within that time frame. If we have 6 weeks, we use 6 weeks. And eventually we teach the patient what they need to continue doing at home after treatment is complete. In most cases, we try to provide a comprehensive rehabilitation program because spinal problems rarely exist in isolation. The spine affects everything: the liver, the kidneys, the gastrointestinal system, the lungs, and much more. If we're dealing with the female pelvis, reproductive health becomes part of the discussion, including the consequences of previous pregnancies and childbirth. If we're dealing with the male pelvis, we must also consider reproductive organs, prostate health, and related functions. Once the body begins deforming to this extent, and remember, we're only discussing one plane of movement here, while left-right asymmetries are occurring at the same time, it becomes obvious that internal structures are affected as well. Organs shift, adhesions develop, tissues adapt, and when rehabilitation begins, one of the first questions is, where are the greatest risks? What is most important? Where do we start? The first few days are often spent determining priorities and deciding on the proper sequence of treatment. Patients actively participate in that process. We discuss the rationale behind the treatment strategy. We talk about goals. We talk about priorities. Of course, patients have their preferences, but ultimately, we still follow the clinical plan that offers the greatest chance of success. So, let's return to the topic of these so-called pathological fractures that seem to occur out of nowhere. In reality, they don't happen out of nowhere. What we're often dealing with is impaired blood supply to the vertebrae, the discs, the joints, and the entire ligamentous and capsular system of the spine. Then we get an X-ray report, and suddenly, we see findings that sound alarming. A compression fracture, a collapsed vertebra, structural deformation, and naturally the question arises, what should we do? As I've said before, radiologists often describe these changes as compression fractures because the architecture of the vertebra has clearly been altered. We can see that the vertebral body has become compressed. The disc has lost height. The structure has collapsed. From an imaging standpoint, the word compression is entirely reasonable. The problem is that long before we ever saw this compression, other processes were already underway. Blood vessels had been compressed. Venous drainage had been impaired. Microcirculation had deteriorated. Tissue nutrition had gradually declined. But none of that appears on a standard X-ray. Those processes remain hidden behind the scenes. To visualize them directly would require much more invasive diagnostic techniques involving contrast agents and advanced vascular imaging. That is a completely different level of investigation. Now here's the key point. If we can optimize blood flow and restore tissue nutrition, even these structurally altered vertebrae can begin to stabilize themselves. Instead of continued osteoporosis and progressive weakening, the body may initiate a process of strengthening and consolidation. In medical terms, we begin to see osteosclerotic remodeling. In practical terms, the vertebra becomes stronger. It's almost as though the body creates its own internal reinforcement. The stabilization occurs through the organism's own biological resources rather than through externally injected cement. And when that happens, invasive procedures may become unnecessary. This brings me back to the anatomical morphological functional approach that we've developed and use internally. When we evaluate the spine through the AMF framework, we analyze every structure individually, every vertebral segment, every disc, every meniscus, every ligament and joint capsule. For each structure, we ask several questions. How has its shape changed? How has its architecture changed? How has its morphology changed? How has its function changed? What has happened to blood inflow? What has happened to venous outflow? What has happened to lymphatic drainage? How are neural trophic mechanisms functioning? What level of biological and energetic resources is the body allocating to that region? And where are the deficits? Only after answering those questions can we design an individualized treatment strategy. The interventions themselves may be biomechanical. Their purpose is to improve alignment, restore form, improve circulation, and enhance lymphatic drainage. When circulation improves, metabolic activity improves. When we improve shape and alignment, we create decompression. When we restore muscular function, we improve both blood inflow and venous outflow. As these deep stabilizing muscles become stronger, they begin supporting the spine more effectively. Range of motion expands. Confidence returns. The sense that the spine is fragile and vulnerable gradually disappears. And patients often become much more active and physically engaged in their lives. Let's talk specifically about patients whose vertebrae have undergone this kind of pathological collapse. Not a traumatic fracture. Not the result of a major accident. A pathological collapse caused by osteoporosis and progressive deterioration of the vertebral architecture. I often compare it to a sugar cube. Imagine a sugar cube getting wet. At first, it looks intact, but gradually it begins to soften and crumble. The vertebra can undergo a similar process. Its internal structure weakens. Its architecture loses integrity. And eventually it starts collapsing under loads that would normally be harmless. This is why surgery is always a matter of careful consideration. Can we inject cement into the vertebra? Of course we can. Technically, it can be done, but we have to ask several important questions. Will it truly improve the patient's condition? If the answer is clearly yes, that's one situation. Will it restore circulation? No. Will it improve the biomechanics of the affected segment? No. Will it stop the underlying degenerative process? No. Therefore, such procedures are often best understood as necessary supportive measures rather than definitive solutions. The procedure itself may be successful, but what happens afterward? At some point after surgery, the patient should ideally say, "I feel significantly better," and sometimes they do. But if the underlying causes remain unchanged, the fundamental problem still exists. That's why treatment decisions are never simple. It's always a matter of choosing the most appropriate strategy for a particular individual. And this is one reason why surgeons themselves often disagree.